Welcome to the online course for diabetes educators. I am Dr. Sukanti Kumaran from Chalaram Diabetes Institute, Pune. Let's talk about Module 1 and I'm going to talk about Section 4 and 5. Module 1, as you all know, is Introduction to Diabetes. The Section 4 deals with classification of diabetes. As you all know, there are four major classifications of diabetes, which are type 1 diabetes, type 2 diabetes, gestational diabetes mellitus, which is diabetes happening in pregnancy, and other specific types. We'll talk a little more in detail of each of the following. Type 1 pathophysiology, I'll be talking in more detail after a couple of more slides. Let's focus on specific types of diabetes here. The genetic defects of beta cell. Example is maturity onset diabetes of the young, where there is a monogenetic, which means one gene defect in the beta cell function. It is characterized by the onset of hyperglycemia at an early age with impaired insulin secretion, with minimal or no defect in insulin action. Again, here the insulin action is almost normal, but it's the beta cell which is not doing its function properly. The second genetic defect where beta cells are fine, however the insulin action is a defect. The third category of specific types of diabetes belong to a condition where the problem is with the exocrine deficiency of pancreas. This can happen secondary to pancreatitis. Pancreatitis is probably secondary to excess alcohol abuse. It could be secondary to trauma, or a cancer of the pancreas can lead to diabetes. And there is a condition called fibrocalculous pancreatopathy, FCPD. This peculiar form of pancreatitis causing diabetes is very common in tropical regions like India. However, the incidence is going down lately. And then the next category is the drug or chemical induced diabetes, as happens with antiretroviral like HIV treatment medication, sometimes pathologically induced by streptozotocin, which is usually used in guinea pigs to induce diabetes in the experimental animals. Now let's go on to section 5, pathophysiology of diabetes. As I said, we'll talk in detail about normal insulin and glucose physiology and how it is affected in type 1 and type 2 diabetes. In this picture, as you can see, pancreas secretes insulin in response to the glucose level in the blood. When there is high glucose after food, obviously the pancreas is told to produce insulin. So the beta cells produce insulin. And what does this insulin do? It makes sure that the glucose from the blood gets into the cell for the metabolism. This is very simplified form of explaining how insulin works in response to glucose and how the glucose enters the cell. Now, in type 1 diabetes, where there is absolute insulin deficiency, the beta cell is at fault. It is not able to produce enough insulin. As you see in this picture, there is pancreas, there is glucose in the blood, but the pancreas, in spite of sensing the amount of glucose, is unable to produce insulin. Therefore, the glucose, even though is present in large amounts in the blood, it's unable to get into the cell for the metabolism. So this is absolute insulin deficiency. As explained earlier, this is being clearly shown in the picture. The reason why there is beta cell defect is antibodies are produced against the own beta cells. As you see in this picture, the islet cells, which are the source of insulin, are killed. How? Because of the production of antibody. As you see in this picture, the insulin pieces and other cell fragments are taken into the lymph nodes, which produces the antibodies. These T cells from the patient's own body act against their own islet cells and kills them. Therefore, the islet cells are unable to produce insulin. So, type 1 is characterized by beta cell destruction or an autoimmune response, as a result of which there is lack of insulin. It is usually detected before 30 years of age and it accounts for 5 to 10% of cases. Blood may contain markers of the immune destruction of the beta cell. As I said, it's an autoantibody response. Therefore, you do detect antibodies to the beta cells like islet cell autoantibodies to insulin, autoantibodies to glutamic acid decarboxylase 65. So when these markers are present, you can be definite that it's type 1 diabetes. Now let's talk about the pathophysiology in type 2 diabetes. Here, the body does produce insulin from the beta cells. However, the insulin is not as effective, as a result of which more amount of insulin has to be produced to cause small action, resulting in hyperinsulinemia. As you see in this picture, the pancreas produces the insulin in response to the glucose in the blood, and some insulin does do its work by sending the glucose into the cell. However, because of the resistance, in other words, the insulin is not in good shape, more insulin has to be produced, and this becomes a vicious process which will further decrease the sensitivity and thereby decrease the amount of glucose entering the body cell for metabolism or energy utilization. And what are the factors which will make it worse? Central obesity also leads to insulin resistance. So as I explained earlier, insulin resistance leads to compensatory excess insulin production or hyperinsulinemia from the pancreas. This in itself will lead to eventual decline in the insulin production because the pancreas after a while will get tired. It's going to say, sorry, I cannot produce insulin anymore, at which point type 2 diabetes patient also require insulin from outside. So the falling insulin secretion leads to hyperglycemia further, which results in diabetes. Frequently, this kind of type 2 diabetes goes unnoticed for several years in spite of the hyperglycemia. Then slowly it worsens, and at the earliest stage, even though it is not severe, since it's not detected, it continues to work on different body organs and starts showing its effect there. And this is usually associated with other metabolic abnormalities like dyslipidemia and hypertension. So what are the risk factors for type 2 diabetes? Physical inactivity, which causes a sedentary lifestyle, and central obesity. First degree relatives with diabetes. There are certain ethnic groups which are known for developing diabetes, like Asian population, African Americans, Latinos, Native Americans, Asian American. So even though the Indians, for example, Asian, have settled in America, they seem to have a higher incidence of diabetes when compared to Americans themselves. So Asian American is one category, Pacific Islander. Also, women who deliver baby who are 4 kgs or more, or who are diagnosed with diabetes during pregnancy, which is called gestational diabetes mellitus. If there is HDL or the good cholesterol, the way you remember is H stands for happy. The higher the number, the happier you are. So HDL is a good kind of cholesterol. If it is less than 35, or if there is triglyceride level of more than 150 milligram per dl, they seem to be also a risk factor for type 2 diabetes. Women with polycystic ovary syndrome, patients with hypertension more than 140 over 90 millimeters of mercury, or who are on treatment for who are on treatment for blood pressure. If the patient has a history of borderline high glucose, they are also at risk for developing diabetes later date. Other clinical conditions associated with insulin resistance, as I mentioned earlier, obesity, and another risk factor is history of cardiovascular disease. So what are the key messages? As you see, diabetes prevalence is increasing globally and in particular in India. It is characterized by high blood glucose levels and is mainly divided into 4 subtypes. Type 1 is characterized by insulin deficiency, whereas type 2 is characterized by a combination of insulin deficiency and insulin resistance. Thank you. Welcome to online course for diabetes educators. I am Dr. Suganthi Kumaran from Chellaram Diabetes Institute, Pune. Here we are going to talk about Module 4, Pharmacotherapy of Diabetes. Mainly we are going to focus on injectables. So what are the learning objectives? To learn the principles of pharmacotherapy in diabetes, to have a basic understanding of the benefits and risks of various anti-diabetic agents, to know how to empower the patient with the knowledge about the side effects of the medicine and how to prevent them, to have a general insight into optimizing and intensifying or de-intensifying diabetes therapy, These are the general learning objectives of this module. As I mentioned, I'm going to be talking to you about injectable therapy in diabetes. There are three categories of injectables. One is insulin. Second belongs to a category called GLP-1 receptor agonist or analogs. And the third is a combination of both insulin and GLP-1 receptor agonist. Let's talk about the indications for insulin therapy. All type 1 diabetes patients are candidates for insulin therapy. In some type 2 diabetes patients, of course, as I mentioned earlier, after the oral anti-diabetic medications start to fail, the patient needs insulin injections to control the sugar. Gestational diabetes, we recommend insulin because it's safer in pregnancy. Category of fibrocalcific pancreatic diabetes also benefit from insulin therapy. Stress hyperglycemia in hospitalized critically ill patients, even though they don't have diabetes, we still prefer insulin because of the quicker acting nature and better control of blood sugar. Now, insulin use in type 2 diabetes patients. When there is oral anti-diabetic medication failure, as I mentioned earlier, type 2 diabetes does not get controlled with medications, so we start them on insulin. Type 2 diabetes, during periods of stress, again we can consider giving them insulin, as I mentioned earlier, because of the quicker acting nature and better control of sugar. This is a preferred modality. What are the examples of stress periods like surgery, any infection, acute coronary event like myocardial infarction? In severe renal or hepatic disease, insulin is an excellent choice. The reason being the side effect of oral anti-diabetic medication are not present in here. And as I mentioned earlier, it's shorter acting and it's eliminated faster from the body. In complications of diabetes like hyperosmolar, hyperglycemic, non-ketotic syndrome, again we consider giving insulin. So why do we consider insulin? As I mentioned earlier, for rapid control and tighter adjustment in emergency surgeries. In lean type 2 diabetic patient, again we consider giving them insulin because they are already in the catabolic state. Intolerance to oral drugs. In women with type 2 diabetes who are planning to get pregnant, we prefer insulin for both tighter control prior to conception and also, as we know, insulin is safe during pregnancy. Let's look at a case. A 62-year-old lady with type 2 diabetes for 15 years on metformin 2 grams and glimepiride with osmotic symptoms, polyuria and polydipsia comes to the hospital. Her BMI is 26 kg per meter square. Lab shows fasting blood sugar of 288 milligrams per dl, postprandial of 340 milligrams with a HbA1c of 13.4%. So the question here, what type of insulin should be prescribed in this patient? What should be the initial starting dose of insulin? So let's talk a little bit about normal insulin physiology before delving into the treatment. In a normal patient, whenever the patient eats, there is spiking of blood glucose, as you see here, which is stimulating the prandial insulin secretion. So both the peak of blood sugar and the body's peaking of insulin, prandial insulin, coincide and bring down the blood sugar together. And in between these meal spikes, there is blood sugar production in the body by liver and small amount by kidneys as well. This is called the basal sugar level, which is controlled by the normal basal insulin. So basically in our body, there is a basal insulin episode or basal insulin which takes care of in between meal blood sugar level, and there is prandial insulin which takes care of the sugar spikes which happens after eating. There are different types of insulin: short acting, intermediate acting, and pre-mixed insulin, which has a combination of short and intermediate or long acting insulin. Examples of short acting insulin include regular insulin, Lispro, Aspart and Fiasp, and Glulysin. Examples of intermediate and long acting would be NPH insulin, Glargine, U100 and U300 or the types, Detamir and Degludec. The premix insulin contains 30-70 ratio, where the 30 would be the regular insulin and the 70 part would be the intermediate or long-acting one, NPH. Then you have analog premix as well, 30-70 aspart mid-start. I will explain all this in detail in future slides. The other combination besides 30-70 are 25-75 and 50-50. In 25-75, 25 would be the Lispro and the 75 would be the longer acting one. In addition to these, we also have degludec with aspart. Now, let's talk about classification of human insulins, and then the next slide will talk about analogs. Human insulins are similar to the insulins in our body, which is basically prepared by DNA recombinant genetic engineering. Recombinant DNA genetic engineering, which produces human insulin. It's usually produced in bacteria. And again, these are classified into short-acting, intermediate-acting, long-acting, and premixed. Short-acting, as the name sounds, it's shorter-acting, acts within half an hour to 1 hour, peaks within 2 to 4 hours, and then it lasts for about 4 to 6 hours, the total duration of action for short-acting regular human insulin. The intermediate-acting examples are NPH and Lentec. It starts to act by 2 to 4 hours. Peak action lasts about 10 to 16 hours, and the total duration of action lasts from 20 to 24 hours. The long-acting is the ultra-Lentec. It acts after 6 to 8 hours, lasts for about 32 hours with a peak between 14 to 20 hours. Pre-mixed insulin, as I mentioned earlier, it has a combination of short-acting and intermediate-acting or long-acting. In this case, regular and intermediate-acting, which is NPH. It starts to act within half an hour and peak action of 2 to 10 hours and lasts for about 12 to 18 hours. This is one of the commonly used insulin, regular and NPH. Now looking at the classification of analog insulin, analogs means they are similar to the human insulins. And the reason why they are called analogs, they are synthetic insulins. Again, these are classified into short-acting, long-acting and premixed. We do not have intermediate-acting insulin in the analog category. The short-acting includes Lispro, aspart and glulisine. As the name says, it is short-acting. In fact, shorter than the human insulin. It acts within 5 to 10 minutes, reaches a peak in 1 hour to 2 hours, and then it's out of the system by 4 hours. Longer-acting ones include glargine, detamere, and degludec. Again, they start acting within 30 minutes to an hour. They don't have a peak action. In fact, they have a plateau, uniform action for about 24 hours in the case of glargine and detamere. Degludec is a longer acting insulin which can even last for up to 3 to 7 days. The premixed insulin category includes a combination of short acting protamine with a longer one, which is 30:70 is one ratio. The other ratio that is available is 50:50. This acts within 5 to 10 minutes, lasts for about 18 hours. The peak is between 1 to 8 hours. Now, what are the advantages or disadvantages of human insulin versus analog? In the case of regular insulin or a human insulin, the absorption is slow. However, it has a longer duration of action of 6 to 8 hours. Whereas rapid-acting analogs, the absorption is faster. However, the duration of action is smaller, which is only 2 to 4 hours. Regular insulin, onset of action takes an hour, up to an hour, whereas analog acts quickly within 5 to 15 minutes. Since regular insulin takes about half an hour to 1 hour before it starts acting, it has to be taken at least 30 minutes before meals. But the rapid-acting analogs has the advantage of taking just before meals or even immediately after meals. The risk of hypoglycemia is higher in the case of regular insulin when compared to the rapid-acting analogs. And the cost, of course, is inexpensive when compared to the rapid-acting analogs. Now, there are different types of insulin, as I have mentioned earlier. This is a graph which depicts the various kind. As you see, the long-acting or the glargine shown in the pink curve takes a while before it reaches its action peak, which is about 2 to 4 hours. But once it reaches, it plateaus. There is no specific peak beyond that. Whereas long detamere also takes about long-acting detemer also takes about an hour or two before it slowly races in the blood. And then it kind of plateaus, however, it does follow a dip after about 12 hours and totally out of the system by 16 hours. Intermediate action, for example, NPH, it reaches a peak around 4 hours out of the system by 12 to 14 hours. Short-acting insulin, as you see, peaks faster, reaches a peak by about 1 to 2 hours and is out of the system by 6 to 8 hours. As the picture shows, a rapid-acting insulin reaches a peak faster also by around 30 minutes to 1 hour and out of the system by 2 to 3 hours. So this picture depicts the various kinds of insulin. Long glargine, once it reaches about 2 to 4 hours in the system, it stays that way, plateaus out throughout the day. There is no specific peak beyond that. Whereas the rest of the insulin, rapid, short, intermediate acting and long acting long acting, especially the detemer, do have a peak and then they are out of the system quickly when compared to glargine. So now let's look at the structural properties of short-acting analogs. As I said, analogs are synthetic insulin. How are they different from the human insulin? Lispro, there is reversal of amino acid proline at position 28 and lysine at position 29 on insulin beta chain or B chain. What they mean is at position 28 there is proline and position 29 there is lysine in human B chain. This has been reversed in Lispro. What happens is in position 28, instead of proline, lysine is present. And instead of lysine and position 29, proline has been substituted. Hence, this becomes the Lispro insulin. The other kind, aspartate insulin, here the proline in position 28 on the beta chain or the B chain of insulin is replaced by aspartic acid. The third kind short-acting analog called glulisine, there the asparagine has been replaced with the lysine. Replacing asparagine with lysine at position 83 and the glutamic acid for lysine at position B29 happens. So these are the structural properties or the variations which has been done in order to produce the analogs. In the case of long-acting analogs, what are the structural changes that has happened? In glargine, asparagine replaced with glycine at position A21. A is the A chain of insulin and the 21st position. And two arginine amino acids are added at position B31 and 32. And what is the structural property or the change in detemer? A fatty acid acylation to the lysine residue on position B29 has been added. The degludec or the longer acting, which almost acts for about 3 days. What is the structural amino acid alteration? Here there is a deletion of threonine at B30 and addition of 16 carbon fatty acid to lysine at B29 via a glutamic acid spacer. There's another recent aspart insulin called FIASP, faster acting insulin aspart. It's faster acting insulin as the name suggests. Here there are two components have been added. The niacinamide, which is vitamin B3, and L-arginine, an amino acid. The B3 helps with the faster absorption of insulin and L-arginine happens to make this compound a more stable compound. So this results in the absorption being done faster. At the same time, aspart maintains or is stabilized. It doesn't disintegrate very fast. However, it acts very close to the human insulin. FIASP therefore can be taken 2 minutes before or up to 30 minutes after starting a meal. That's the advantage of taking FIASP. As I mentioned, it has an earlier peak when compared to other fasting acting insulins. It is approved by the FDA for adults with type 1 and type 2 diabetes and it's available in 10 ml vials and as well as in the FlexTouch pens. These are the various concentrations of different longer acting and regular insulin. Long acting insulin like degludec, glargine, short acting insulin like Lispro and regular. It comes in concentration of 200 units per ml, degludec in 200 units per ml. Glargine actually comes in both 100 units per ml and 300 units per ml. Lispro, higher concentrations comes at 200 units per ml. Regular insulin is available at two different concentrations, 200 units per ml also and 500 units per ml also. So what is the advantage? Higher concentration insulins are used in patients who have severe insulin resistance and high insulin requirement. The advantage is giving larger concentration with small amount of insulin. Only Glargine U300 and regular U200 are available in India. While regular insulin is not usually prescribed in developed countries like UK, it is still prescribed due to its lower cost, especially in India. So Glargine U300, it has a strength of 300 units per ml and it has lower variability when compared to Glargine U100. It higher or similar doses for the same effect, longer duration of action, and it is much smoother, causing low rate of hypoglycemia, less weight gain, and less nocturnal hypoglycemia. However, the limitation of this is the pen device allows one to take only 18 units in one dose. So prescribing insulin basically involves using insulin injection devices, how to store, especially during the time of travel, the techniques of giving insulin injection, like which is the site, better site, how do we mix insulin, about the reusage of the needles, how it has to be disposed, and hypoglycemic management. All this has to be addressed and it's separately discussed about insulin administration and all the details in a separate module in detail later. However, one would know from the picture here how the insulin has to be taken. The cloudy insulin is basically NPH. The pen, how does it look? The cartridge, how it has to be replaced. And a pump, how does it look? And what insulin generally goes into the pump. All this, as I mentioned earlier, will be discussed in detail in a different module. Now, dosage of insulin, there is no hard and fast rule to assess the initial dose. Ideally, it is better to start slow and small and gradually increase at the interval of 2 to 3 days, as judged by the plasma level. Usually, the initial dose is 0.5 unit per kilogram per day for type 1 and for type 2, 0.2 units per kilogram per day. As mentioned earlier, type 2, more of an insulin resistance category, wherein the body itself has enough insulin, except it's not as efficient. That's why the unit is only 0.2 unit per kilogram, unlike type 1 where there is total deficiency of insulin and therefore we have to give 0.5 units per kilogram per day. And especially type 2 diabetes patients who are taking oral anti-diabetic medication, again the dosage of insulin should be started slow at 0.2 units per kilogram per day. 50% is usually given as basal dose and the rest of the 50 is given as boluses depending on which regimen is used. Again, basal insulin is started with 0.25 unit per kilogram body weight at bedtime and slowly titrated once in every 2 to 3 days. Pre-mixed insulin, we start at 0.5 unit per kilogram body weight. In this case, pre-mixed is given 2/3 in the morning and 1/3 in the evening for regular pre-mixed. However, if it's analog, then we give half in the morning and half in the evening because of the efficiency with which it gets into the blood and the way in which it clears the blood faster. Unlike the regular premixed, where it takes a while before it reaches the peak and takes for a longer time before it leaves the blood. Basal bolus insulin, again the dosage is 0.5 units per kilogram. Half is given as basal and the other half is divided into 3 equal doses before meals. Side effects of insulin. Insulin can cause hypoglycemia, as we all know. It should be treated with oral or intravenous glucose as per the severity. Hypoglycemia can be prevented by eating regular meals on time. The disadvantage also is weight gain, especially in the abdomen. It can be mitigated by appropriate lifestyle. Improper insulin injection technique can lead to problems like infection at the site of injection. Sometimes it causes deposition of the fat in the form of lump when it is called as lipohypertrophy, or there may be destruction of that causing lipoatrophy. Together, hypertrophy and atrophy is called as lipodystrophy. So now that we are done with insulin, let's move on to GLP-1 receptor agonist or analogs. So GLP stands for glucagon-like peptide 1. Now the incretin effect or GLP-1, let's explain what it is. It is responsible for about 50 to 70% of total insulin secretion after oral glucose admission. There was a study where they found the insulin production in the body is high when the food or the glucose is given orally when compared to the glucose given IV. That's when they found out about incretins, which are GLP-1 and GIP, gastrointestinal polypeptide. This is called the incretin effect. Matlab, the production of insulin in response to the oral glucose administration, which is reflected by elevation in GLP-1 and GIP, is called the incretin effect, causing increasing in insulin production. So the incretin effect, responsible for 50 to 70% of total insulin secretion after oral glucose administration, is defined as the difference in the insulin secretory response from an oral glucose load compared with the IV glucose administration. There are two naturally occurring incretin hormones that play a role in the maintenance of glycemic control, which are glucose-dependent insulinotropic polypeptide and GLP-1, both of which have a short half-life because they are destroyed by what is called DPP4, diphosphatidylpeptidase 4. So this enzyme destroys GLP-1 and GIP. So in patients with type 2 diabetes, the incretin effect is reduced or in some cases even absent. So the insulinotropic action of glucose-dependent insulinotropic polypeptide is lost in type 2 diabetes patients. So GLP-1 receptor agonist or GLP-1 analogs or incretins or intestinal hormones which cause glucose-dependent insulin secretion and glucagon suppression. As we know, glucagon produces increased sugar. When you suppress the glucagon, the level of the sugar goes down. So the GLP-1 and GIP act not only by increasing the insulin production, which will allow the glucose from the blood to get into the cell, but also decreases the glucagon, which is responsible for raising the blood sugar. So it acts in both ways. GLP-1 agonist helps in results in weight loss by suppressing the appetite. Chances of hypoglycemia are less as it is dependent on the glucose in the blood. It also lowers the blood pressure. This is generally an idea of what GLP-1 analogs does. When you look at the brain, its action is to suppress the appetite because of increasing the neuroproduction as well. Also, it decreases the gastric emptying, and then it increases the insulin, decreases the glucagon, increases insulin synthesis along with causing beta cell proliferation or beta cell preservation. It decreases the beta cell apoptosis, that is cell death. When we talk about the fat cells, it increases the glucose uptake and the storage. In muscles, it decreases the glucose production as well as in the liver. In the heart, it increases the cardiac function and cardioprotection. So these are the various ways by which GLP-1 analogs work. There are different kinds of GLP-1 analogs like exenatide, liraglutide, albiglutide, but the one available in India is liraglutide. It has a half-life of about 13 hours. It's available in concentration of 0.6 to 1.8 milligram. So initially it's given as a subcutaneous injection, not insulin. Subcutaneous injection started at 0.6 milligram once daily for a week. Then it is increased to 1.2 milligram once daily. Maximum can go up to 1.8 milligram subcutaneous injection daily, once daily. The other kinds which are available in India would be dulaglutide, which is given as 0.7 milligram subcutaneous injection. It can be escalated to 1.5. The difference here is dulaglutide can be given weekly once, unlike liraglutide, which is given daily. Next category is lexisenatide. It has a half-life of about 3 hours. 10 micrograms daily injection is slowly titrated up to a maximum of 20 micrograms after 2 weeks. Another category of GLP-1 agonist injectable kind, semaglutide, 0.25 micrograms. Again, this is given once weekly. So the two GLP-1 analogs which can be given weekly or dulaglutide and semaglutide. Actually, oral semaglutide is in research now. As for now, we have only injectable semaglutide, which is 0.25 milligrams subcutaneously given once a week for 4 weeks initially. Then slowly we increase the dose to 0.5 once a week. The dose can be increased as much as 1 milligram if tolerated well, because the common side effect is nausea and vomiting. Let's move on to case number 2. A 58-year-old male with type 2 diabetes and hypertension for 6 years comes to the clinic. He takes glimepiride 2 milligrams twice a day, metformin 1 gram twice a day, along with enalapril for his BP 5 milligrams once a day. He follows diet very well but cannot regularize due to the obesity and osteoarthritis of knees. On examination, his weight is 122 kilograms with a BMI of 38.2 kilogram per meter square. BP is still on the higher side, 160/90 in spite of enalapril. Systemic examination is within normal limits. Lab values show fasting of 178 with a PP of 245 milligrams per DL with HbA1c of 8.9%. So which drug do we choose in this case? Again, there are different kinds of GLP-1 receptor agonists. In India, liraglutide is available. We would not recommend liraglutide, especially in kidney patients. If the kidney is not in good shape, we have to use caution in the chronic kidney disease. So what are the benefits and adverse effects? Benefit, as I mentioned in the graph or the picture, it has a cardioprotective effect. It helps with the weight reduction in BP, lipid parameters. It protects the beta cell function by improving insulin resistance and glucose homeostasis and lowers the risk of hypoglycemia. What are the adverse effects? The most limiting adverse effect, common adverse effect is nausea and vomiting. Most of the patients discontinue taking this medicine because of this. However, after the first couple of weeks, they get used to it and they tolerate it very well. The vomiting resolves and the patient is able to go up on the higher doses. Acute pancreatitis can also happen. Medullary thyroid carcinoma is known but not common at all. It was found very rarely in the research studies. And the other adverse effect is anti-drug antibody formation, leading to decreased efficacy or hypersensitivity reactions. So what are the concerns we have about GLP-1 analogs? There's a warning towards a rare complication of pancreatitis, but is strongly argued by most authors that the risk is more theoretical than practical. The main black box warning is the thyroid, medullary carcinoma of thyroid, thyroid C cell tumor risk. The contraindications, if the patient has already a personal history or a family history of medullary thyroid carcinoma, we don't recommend this medicine for them. Or patients with multiple endocrine neoplasia, MEN, syndromes type 2, we don't recommend this. And the new data which is revealing cardiovascular outcome improvement for each of these are these studies. For example, in liraglutide, it's a leader study which showed a good improvement in the cardiovascular outcomes. Semaglutide, the study is sustained study. And for dulaglutide, the study which shows improved cardiovascular outcome is the rewind study. Now that we are done with insulin and GLP-1 receptor agonists, let's talk about the combination of insulin and GLP receptor agonists. So this is a very good combination which will also help with the reduction in insulin dose, thereby increase in weight gain happening with insulin goes down. GLP-1 itself will cause a weight reduction. So the combination effect is excellent in weight reduction. So GLP-1 receptor agonists with insulin are an option for add-on therapy to the basal insulin in place of prandial insulin. It also reduces the postprandial glucose, and when combined with insulin, as I mentioned earlier, it reduces the insulin dose. There are fixed ratio combinations of insulin with GLP-1 analogs. So it reduces to one injection. Two injectables in one injection will reduce the number of injections. Ideg-lira, as the name suggests, it contains degludec and liraglutide. That's why it's ideg-lira. Combination of long-acting insulin degludec and liraglutide. It comes in a fixed ratio. That's the disadvantage. Since it's a fixed ratio, we cannot titrate the dose individually. But the advantage is it's just one injection which contains two injectables. The fixed ratio of insulin degludec 100 units and liraglutide of 1.8 mg per ml. That's the maximum dose. The dose can be adjusted by 1 unit of insulin degludec and 0.036 mg of liraglutide, with the maximum dose at one time would be 50 units of insulin degludec and 1.8 mg of liraglutide. Lexilan, I don't think this is available in India. It's a fixed ratio premixed formulation of lexisanatide 1 microgram with glargine 2 units. It has demonstrated glycemic superiority as well. So in summary about the injectable therapy, patient education is very important, especially in insulin naive patients. And this will be talked in more detail under insulin administration in a different module. Newer insulin analogs are to be preferred in a fooding patient as for the obvious reasons that it acts as good as human insulin, reaching the right amount of peak faster and leaving the body faster. Glucagon like peptide 1 receptor agonist can be considered in obese patients because in addition to helping with the blood sugar control, it plays a very good role in reducing the weight as well. Thank you. Welcome to the online course for diabetes educators. I am Dr. Suganthi Kumaran from Chalaram Diabetes Institute, Pune. I'll be talking to you about the comorbid conditions in diabetes, Module 7, about diabetic dyslipidemia, Section 2. So, as we all know, adults with diabetes have 2 to 4-fold higher risk of cardiovascular disease. What are the cardiometabolic risks? It can be classified as non-modifiable risk factors like age, gender, and genetics. Modifiable risk factors like hypertension, hyperlipidemia, hyperglycemia. Metabolic syndrome is also modifiable, and atherogenic dyslipidemia. All these 4 contributes to the cardiometabolic risk. Now, what is atherogenic dyslipidemia? It includes both the qualitative and quantitative changes in lipoproteins like low density lipoprotein, high density lipoprotein, and triglyceride rich lipoproteins, TRL. So what are basically the pathogenesis of dyslipidemia? In these patients, the more atherogenic matlab the ones which forms the plaques in the blood vessels, like more of very low density lipoprotein, high amount of small dense low density lipoprotein, and the good cholesterol, less amount of it, like low HDL. This is the main pathogenesis involved. This together culminates in elevation of non-HDL cholesterol. Especially in postprandial hyperlipidemia, the patients are more prone for atherogenesis. There is decreased amount of protective kind of adiponectins like adipokines. Also, there is more amount of remnant particles formed from hydrolysis of triglyceride-rich lipoprotein. They are rich in cholesterol esterase, therefore they are very atherogenic. They cannot cross the endothelium efficiently, so they end up depositing as plaques. So what are the screening tests that one would do for dyslipidemia? If the patient is fasting, we do a fasting lipid profile which includes total cholesterol, LDL, HDL and triglycerides. However, if the patient is not fasting, it's okay to do what is called non-HDL. That's the advantage of calculating non-HDL cholesterol, which is also bad cholesterol, can be done when the patient is not fasting on lipid therapy and when the triglycerides are more than 200 milligrams per dl. Another screening test that can be performed to study about the cholesterol would be ApoB protein. So what is the management? LDL gold treatment has been recommended now in the updated 2018 ACC and AHA, American Heart Association cholesterol treatment guidelines. Earlier in 2013 also we had LDL gold, and then in between 2013 and 18 they had taken the LDL gold target levels and they were focusing only on reduction. Now as of 2018 we focus both on the reduction as well as a LDL goal, which we will be seeing in the next few slides. And then management also includes on the non-pharmacological part, which is like lifestyle changes, which is already covered in module 3, and the pharmacological management, which involves lipid therapy treatment with medications and effect of the anti-diabetic medication, which has on the lipids also. So what are the various pharmacological therapies available for dyslipidemia? Number one cornerstone of therapy is statins. Then we have other kinds like ezetimibe, PCSK9 inhibitors, fibrates, omega-3 fatty acids, bile acid sequestrants, niacin, and saroglitazole. So as I mentioned earlier, statins is the cornerstone treatment for lipid management. It is a HMG-CoA reductase inhibitor. It is a rate limiting step in the cholesterol synthesis. So once you inhibit that, obviously the cholesterol production goes down. It decreases the LDL by 20 to 60%, triglyceride by about 7 to 37%. It increases the good cholesterol. As I mentioned earlier, H stands for happy or higher. Higher the number, happier you are. That's the way you can remember. HDL, the high density lipoprotein, higher it is, the better off it is for the patient. So it increases HDL by 2 to 16%. There are other effects of statin which seems to be helpful as well, like anti-inflammatory property, anti-thrombotic property, plaque stabilizing property, and increased production of nitric oxide, which causes vasodilatory effect. All these seems to help with the reduction of the cardiovascular disease in the patient. However, what are the side effects of statin? Myalgia is one of the common side effects. Myositis and elevation of AST and ALT. Those two are the enzymes in the liver. When it goes almost 3 times upper limit of the normal, then we have to stop the statin. So what are the monitoring parameters? We look at the lipid and the liver enzymes. We check the lipid just to make sure that the patient is being compliant with taking the medication, and the liver enzymes just to make sure the side effects of the medicine is not happening. So as I mentioned earlier, in 2013 itself, the LDL gold targets have come into place. However, between 2013 and 18, there were some changes where they had removed the target numbers. Now it has been reinstated. So in addition to the goal of reaching the LDL below 70 in cardiovascular disease patients, we also decide about the intensity of the statin therapy. For that, we need to read about the risk. We have to calculate the risk as shown in the picture. Patients 25 years of age or older without heart failure, New York Heart Association class 2, 3 or 4, or end-stage renal disease undergoing hemodialysis, they should be screened for cardiovascular risk factors. And then they measure the LDL cholesterol. So these are the two things that you do for a patient with 21 years of age. Check for the cardiovascular risk factors by using a calculator and measure the LDL cholesterol. If they do have atherosclerotic cardiovascular disease and the age is less than or equal to 75, we start them on in high intensity statin. Now what is high intensity? There are basically high and moderate intensity. High intensity statin is the one which brings the LDL cholesterol by 50% or more from the baseline. Moderate intensity, it reduces the cholesterol, LDL cholesterol, between 30 to 50%. So, if the patient has a clinically atherosclerotic cardiovascular disease, irrespective of the amount of the LDL that they have, you just start them on high intensity therapy. So, from the baseline, it falls 50% below. If the patient age is more than 75, then we go a little easier on the medication. We give them moderate intensity statin. This is about the clinically positive atherosclerotic cardiovascular disease. If the patient has LDL cholesterol greater than or equal to 190, we start them on statin, and that would be high intensity, which is to reduce the level by 50% or more. If the patient has diabetes and the age is between 40 to 75, again, and the cholesterol is between 70 to 189 milligrams per dl, we start them on statin. We calculate the atherosclerotic cardiovascular 10-year risk only to decide between moderate and high intensity statin. 40 to 75 years with the diabetes, LDL 70 to 180, we start them on statin. We calculate the 10-year risk to decide whether we wanted to reduce by more than 50% or only between 30 to 50. More than 50 would be if the risk factor is greater than or equal to 7.5%. However, the calculated 10-year risk of atherosclerotic cardiovascular disease is less than 7.5%, then we give them moderate intensity. Now, next category or the fourth category where the patient do not have diabetes, however, age is between 40 to 75, LDL cholesterol is between 70 to 189. Again, the next step is to calculate the 10-year risk of ASCVD. Only if the risk is greater than or equal to 7.5, Then we start them either only on moderate to high intensity depending on how many more risk factors keeps adding. So to determine which patient goes on statin therapy, we classify them into four major categories. Clinically present atherosclerotic cardiovascular disease, they have to go on the medicine. LDL cholesterol may greater than or equal to 190. Diabetic mellitus patients with age 40 to 75 and LDL of 70 to 189. No diabetics, however, their LDL cholesterol is 70 to 189 with a calculated 10-year risk greater than or equal to 7.5. So let's continue with the statin. As I mentioned earlier, high intensity statin will reduce the LDL cholesterol by 50% or more. Examples of high intensity statins would be atorvastatin, 40 or 80 milligrams would be the dosage, or rosuvastatin, 20 or 40 milligrams. Moderate intensity statin therapy will reduce it 30 to less than 50% of LDL. Again, what are the statins which can be used for moderate intensity statin therapy? Atorvastatin at a lower dose, 10 to 20, or rosuvastatin, 5 to 10 milligrams. Others would include simvastatin and pravastatin. These can be given once a day because it's longer acting. And the studies have shown that for every 1 millimole or 38.7 milligram per dl reduction of LDL, the cardiac heart disease goes down. The cardiovascular disease goes down by, or coronary heart disease goes down by more than or equal to 50%. Again, this has been shown by the research. So statins are really good for our health. Now, the indications which I had mentioned earlier in diabetic patients, history of atherosclerotic cardiovascular disease, irrespective of the age, they have to go on high dose. If there is a cardiovascular risk factor, however, patient is less than 40 or greater than 75, we give moderate or high dose depending on the number of risk factors added. 40 to 75, definitely diabetic patients have to be on high dose. No risk factor at all. Diabetic patients less than 40, no need to be on statin. However, 40 to 75, definitely moderate dose. More than 75, also moderate dose. So what are the cardiovascular disease risk factors that they're talking about? LDL cholesterol more than or equal to 100 milligram per dl, high blood pressure, smoking, chronic kidney disease, albuminuria, and family history of premature atherosclerotic cardiovascular disease. These are all the cardiovascular risk factors that are taken into consideration. Now let's move on to the next category of pharmacotherapy for dyslipidemia, acetamide. It is basically intestinal cholesterol absorption inhibitor. It is cheap and effective. It reduces by another 20% when added to statin. Let's say you give statin to the patient. However, the patient is unable to tolerate the higher doses because of elevation in AST and ALT, the liver enzymes. We try to not increase the dose of statin. When it stabilizes, but still the LDL is not at goal, we start adding another category of medicine, for example, acetamide. So, because our goal is to just bring the LDL cholesterol to the goal. So it reduces LDL by another 20% when it is added to statin. It is recommended by the updated guidelines to achieve the LDL goal after statin. So first line of treatment is statin. On top of statin, then we start adding other drugs to reach the LDL goal if the patient is unable to tolerate higher doses of statin. Third category of medicines are fibrates, omega-3 fatty acids. It belongs to what is called PPAR, peroxisome proliferator activated receptor, alpha agonist category, fibrates. It decreases the triglyceride. Fibrates mainly reduce the triglycerides. On the side, it also happened to help with the reduction in LDL. It increases the HDL a little bit, 10 to 20%. When triglycerides are more than 500, fibrates are indicated. Used to prevent the pancreatitis. More than helping with the cardiovascular disease reduction, fibrates are given to reduce the triglyceride so that the patient will not get pancreatitis. Omega-3 fatty acids, same pathogenesis. It reduces the triglycerides. In fact, there was a recent trial, reduced trial, which had shown that omega-3 fatty acids do reduce the cardiovascular diseases. However, these are purified omega-3 fatty acids, unlike the supplements. So it is better to take it as a part of a diet rather than taking as supplements, because when omega-3 fatty acid supplement are taken, to produce an effect which is caused by purified omega-3 fatty acid, about 20 to 25 capsules have to be taken. which will also contain other impurities, and it will keep adding on to the system, causing eventually some kind of side effect. So the right way to do is just eat a balanced diet which is rich in fish, nuts for vegetarians. So the omega-3 fatty acid goes up. What are the omega-3 fatty acids? EPA, eicosapentaenoic acid, and docosahexaenoic acids. As I mentioned earlier, diet rich in fish, either 2 servings per week is recommended, or increase the nuts and flax seeds. So as I was mentioning earlier, a recent study has evaluated the effect of eicosapentaethyl. This is a purified or synthetic form of omega-3 fatty acid on cardiovascular events in diabetes as well as other high-risk population. And this is the first study which revealed that there is a 25% reduction in the cardiovascular events by reducing the triglycerides. However, more research is needed in this regard. Now let's move on to the other pharmacological management. Bile acid sequestrants are used like colsavilam and cholesterol. It's safe in pregnancy. However, it has a side effect of increasing triglycerides. Niacin seems to elevate HDL. However, it will cause hyperglycemia and hyperuricemia. Because of these side effects, it's not very popular. PCSK9, which stands for pro-protein convertase subtilisin kexin 9 inhibitors, examples of which are alirocumab and evolocumab. These are available as subcutaneous injections, very expensive, but this can be used as an add-on therapy to statin if the LDL goal is not reached yet. So in summary, diabetic dyslipidemia is very common. Early screening and prevention is very important. Statins are the cornerstone of lipid therapy in addition to the lifestyle changes. Lifestyle is the basic for any diseases for that matter, starting with diabetes, hypertension, cholesterol, and we can go on and on. Medications come as the next steps to the lifestyle changes. And as mentioned earlier, ezetimibe and PCSK9 inhibitors can be added to statins if goal LDL is not met. Thank you.